So we're now going to switch focus, and our next two presenters are both co-directors of the CU Center for Rare Melanoma. The CU Center for Rare Melanomas is a vital component of research and development here on campus. Our first presenter is an active investigator within our clinical trials and within lab. He has dedicated countless hours to the new development and lab work dedicated to new targeted treatments, rare melanoma features and genotyping, treatment response, and more. He's an investigator, professor, provider, and endowed chair at CU Anschutz. Please help me in welcoming Dr. William Robinson.
Thanks very much, and thanks for putting this program together. We're most appreciative. University of Colorado has had a major melanoma program in place since the early 1970s. Most of that is focused on cutaneous or skin melanomas, where we've made great advances over the years. But more recently, particularly within the last 4 or 5 years, we've also developed an interest in rare melanomas, and I'm going to show you what those are. But most of the driving force behind the development of the rare melanoma program belongs to my colleague, Casey Couts, you'll hear from next. She was really the driving force behind this rare melanoma program. Let's go to, I want to go back just a little bit and show you what melanoma is. Everybody thinks they know what melanoma is, but I'm not sure that everybody's clear about it. It's a cancer of the melanocytes. Everybody knows that. They are the cells that produce melanin, which is the pigment that gives your skin its color, gives your eyes its color, give your hair its color, etc. And melanocytes are present in all areas of the body of the skin. The mucous membranes, there are a few in the brain and in the meninges, and I'll show you a diagram of that in just a minute. Their function, at least in the skin, is to protect the cells in the skin from damage from ultraviolet light, and I'll show you how that works. The function in other areas is unclear. That is, let me show you. If you have melanocytes in your rectum or in your vagina, why are they there? I mean, what are they doing? I don't think we know the answer to that. So here's what these melanocytes look like. Here's the skin of an adult. The pink things here are the epithelial cells, and down below the epithelial cells are the melanocytes, and they look kind of like an octopus. And every bit of your skin, your epithelial skin, has these melanocytes below it. Melanocytes are connected to every bit of your skin. I'll show you that in just a minute. And the function of the melanocytes, at least in the skin, is they pump melanin, these little black dots here, up into these epithelial cells. That's what gives your skin its color. And there are different kinds of melanin that are made dependent upon your ethnic background. I'm not going to belabor this. Just want to make the point that they're everywhere. So this is the number of melanocytes per square millimeter of skin. They're present in the scalp, in the forehead, on the nose, in the mucous membranes inside of the nose, and in the sinus cavities. They are there. They're also present on the scrotum, for example, the foreskin, inside the vagina, inside of the rectum. And the number of melanocytes in various areas of the skin and mucous membrane is about the same. That is about between 1,000 and 2,000 per cubic millimeter. And I emphasize to you that these melanocytes are present in every epithelial and mucous membrane area of the skin. And they're also present in the eye. You already heard a little bit about ocular melanoma. This is a cross-section of an eyeball right here. And the melanocytes sit back here in the back and a few in the front and in the cornea. And they protect, again, the nerve cells in the eye from ultraviolet damage. That's why they are there. And so you can develop a melanoma anywhere you have melanocytes. We know that most of the most of the melanomas are in the skin, about almost 90%, and they are related to ultraviolet light. There are some melanomas that develop on rarely exposed sites. The bottom of the foot, they're called acromelanomas. They're a small percentage of all melanomas. And then there are the melanomas that develop on non-cutaneous sites, mucosal melanomas and uveal melanomas that begin in the eyeball. And I'm not going to go into all of these in a lot of detail, but we'll come back and look at these individual ones here. But the point I'm going to make in this talk is that the mucosal melanomas are different than skin melanomas, are different than acromelanomas. They're different molecularly. They're different in how they respond to treatment. And we have quite effective treatments here, but we don't have very effective treatments down here. So the overall survival rates, as I just mentioned, for all cutaneous melanomas, everybody who walks through your door is about 80% at 5 years. Acromelanomas, about the same. But when you come down here to mucosal melanomas, the 5-year survival rate is only 25%. And in eye melanomas, a fair number, 25% of people ultimately succumbed to ocular melanomas. So here they are again, the number of cases in the US, most again, 87% of melanomas are on the skin, 3% on acral surfaces, and only 1% in these areas, but they don't respond to treatment. I just made that point. Now, we, over the past 25 years, as we've had rapid methods of looking at genes present in cells, have begun to characterize melanomas and other cancers, not so much by where they are on your body or where they grow, but their molecular characteristics. That is, what mutations they have. And I'm going to illustrate for you the difference in the molecular mutations, the mutations that occur in skin melanomas versus these rare mucosal melanomas. So if you look at the rare melanomas and mucosal melanoma underneath the microscope, if you're a pathologist, you can't tell it from a skin melanoma. You can't tell the difference at all. Looks the same. But when we do the molecular studies and characterize the genes that are present and mutated, they're very different. So I'm going to illustrate that only with one. And this is a gene which is called BRAF. And it's called BRAF. And that gene, BRAF, is mutated in about half of all cutaneous melanomas. And we can, in fact, target that gene with a molecularly targeted therapy. So now we did a whole gene sequence of the cutaneous melanomas, and we then sequenced the mucosal melanomas and the acral melanomas. And what we show is that they're very different. So if we just look at BRAF, you don't need to look at anything else for the time being. 50% here, but in acral melanomas, only 10% have a BRAF mutation. You come over to the mucosal melanomas, 7% have that gene mutated, but they have a bunch of other mutations. And in eye melanoma, there are essentially no BRAF mutations. All this shows is the differences between these various kinds of melanomas when they are analyzed by gene variations, not simply by what they look like underneath the microscope. Now, I emphasize, too, that these mutations are not mutations that you're born with. They're not mutations that you carry because your parents pass them on to you. These are mutations that occur after you're born, and they occur only in the melanoma itself. They don't occur in other parts of the body. Now, what we know is that in cutaneous melanoma, there are lots and lots of mutations. So if you take a cutaneous melanoma and you take it to the laboratory and we look at it and do the molecular studies, they're full of mutations. The average cutaneous melanoma has maybe 10,000 mutations in it. And we know that the more mutations the melanoma has, the more likely it is to respond to these immunotherapies. I'll mention that a bit of detail. The number of mutations is called the mutational burden. So the more mutations you have, the more likely you are to respond to immunotherapy. It is as though the immune system said, oh man, these are really bad cells. Look at all the mutations that are here. We're going to get rid of it. So here it is right here. This is mutational burden. This is simply the number of mutations present in cutaneous melanoma. And each of these dots represents a single patient. And you see lots of mutations in the cutaneous. In the acral melanomas and mucosal melanomas, mutational burden is low. And this shows the response now to immunotherapy. So for cutaneous melanoma, with this high number of mutations, the response to immunotherapy is about 50%. Well, you get to mucosal melanomas, which have a low mutational burden, the response is very low, and it's almost nil in ocular melanomas that don't have very many mutations. Now, Dr. Mitty's already mentioned the tumor microbiome as part of this, and we know that the tumor microenvironment, if you will, also plays a role in how melanomas respond to various kinds of therapy. And we know that the tumor microbiome, that is the kinds and numbers of bacteria that are present in various areas, also affects how we respond. So in the past, one of the hypotheses that we have put forward, because we have no idea how these mucosal melanomas develop, we have no clear-cut clues. Cutaneous melanoma, almost everybody's Caucasian. Almost everybody has a history of sun exposure. Almost everybody has light-colored hair and blue eyes. Mucosal melanomas run across the spectrum: black, white, oriental, dark hair, light hair. They don't have any similar occupational exposures, etc. They're apparent to your, or seems apparent to you, that they're totally random who gets them. They don't run in families. They're, again, not related to anything that we know of. And when we look at the tumor, so our hypothesis is that the development of these may be related to the microbiome, and not the microbiome in your intestinal tract, but the microbiome where the mucosal melanomas develop. That is the microbiome and the microbial flora that are present in your sinus or in your nasal cavity if you have a nasal melanoma, or in your vagina if you have a vaginal melanoma, in your rectum if you have a rectal melanoma. And I'm not going to go into a lot of detail about that, but that is one of the things that we're working on. So we are comparing the microbiome in mucosal melanoma with cutaneous melanoma patients. So for example, you come in with the nasal melanoma, we sample your microbiome of your nose, and then we use as a control the microbiome in the nose of a patient with a cutaneous melanoma. And we're looking for any microbial organism that might be different between those. We do not have good data. Next year when we do the symposium, hopefully we'll have the data about that. We know that the immune response, and I mentioned this previously, to the mucosal melanomas and eye melanomas considerably lower than it is in cutaneous melanomas. So cutaneous melanomas, combination therapy with immunotherapies of various kinds is about 60%. Aquamelanoma is a little bit lower, but they do respond, but very low response rate in mucosal and uveal melanoma. And here's actually a survival curves of patients treated with various immunotherapies. Here's cutaneous melanoma, here treated with immunotherapy, and then here are the rare melanomas out here. So you get out here to 6 years, the survival of the uveal melanoma, and this is uveal melanomas that have metastasized, is all the way down here to about 15%, for example. And again, we're back to the mutational burden, which I mentioned, and I won't go into the structural variants. So what we have also shown, people have lumped all these mucosal melanomas together. So if you go to the literature or you look at any melanoma database, they just toss all the mucosal melanomas together as though they're the same disease. But what Dr. Kautz has shown is that they're not the same. Now, again, when we go back and molecularly profile these individual forms of mucosal melanomas, nose versus vagina versus rectum, they're different diseases. They have a different molecular profiles, and they have different survival. So, for example, this is the overall survival of various melanomas. Right here is rectal melanoma, and you see if you get out here to 5 years, the number of patients alive with the rectal melanoma is way down here. Cutaneous melanoma is up here, and vaginal melanoma has the best prognosis of all the mucosal melanomas, and then the nasal melanomas are in between, but they are different. That's all I wanted to point out here. Nasal melanomas are most common. Nasal sinus and mouth are most common in men. Of all the nasal melanomas, 27% are in males, 11% in females, and down here, anal rectal melanomas are also more common in males, and of course, the vaginal are exclusively in female. And this is just simply to point out to you that they're different. That nasal is different than vaginal, that is different than rectal. And this is a plot of the mutations that are different in these. You don't have to know very much to look at this. Where there's the filled in is where this gene is mutated. And you see that nasal is different, even though you may not know what these genes are. It doesn't make any difference, but you can see that the pattern is different in nasal than it is in vaginal, than it is in rectal. And I won't go into all the genes that we have looked at. We've also shown in the last year this subungual melanoma. It's underneath the fingernail or the toenail. They're pretty uncommon. They begin at the back of the nail bed back here in the proximal nail fold, and they were previously included in the category that are called acral melanomas. But as a result of a large study done here, we showed that these subungual melanomas were not the same as acral melanomas on the palms and on the bottom of the foot. They were a different category all unto themselves. And I won't belabor this, but these are the genes. And you can see that the subungual melanomas underneath the fingernail or toenail are different than the acral melanomas. And you don't need to know anything about the genes to just see that the differences are there. Well, in summary, and then I'll turn it over to Dr. Kautz in just a minute, most rare melanomas are not sun-related. They are quite different in both their clinical progression and outcome and their molecular profiles in cutaneous melanomas, even though they may look identical underneath the microscope to the pathologist. And the various forms of mucosal melanomas, which previously have been all lumped together, are clearly different from one from another. We don't have any known causative factors for the mucosal melanomas, or indeed for ocular melanomas either. And that's what we are actively looking for. All of the rare melanoma categories respond poorly to the current therapies that are so effective in treating advanced cutaneous malignant melanomas. And we need new understanding, and we need new treatments for this category of melanoma. Thanks.